Well, I would like to thank the organizers for inviting me. Liborio, thank you very much. And honestly, it's really an honor and a challenge to follow Carlos Schenk presentation. This is not good for me, Liborio, so you're a very bad person. But anyway, I'll try to do my best talking about REM sleep and neurodegeneration. These are the main known facts of this presentation, is that abnormalities of REM sleep can be seen in neurodegenerative diseases. But REM sleep amount and latency is normal in neurodegenerative diseases, especially during the early stages of these neurodegenerative diseases. Maybe in the later phases or in very advanced phases, the REM sleep amount is shortened. But what is known, and it will be the focus on this talk, is that increased EMG activity plus drumming active behaviors, also known as REM behavior disorder, is frequent in some neurodegenerative diseases, mainly among the synucleinopathies. And we will see that they are, we will focus on the prodromal stage of these synucleinopathies that we call isolated, idiopathic, or primary RBD, or also when these neurodegenerative diseases, dementia with Lewy bodies, PD, and multisystem atrophy have been established and diagnosed. So, and everything starts here with Mark Howell and Carlos Schenk, even with their seminal description of REM behavior disorder that was made, as he has already said, and you all know, in 1986 in 4 men of 60 to 72 years. But let me highlight that one of them had atypical dementia and the second had olivopontocellular atrophy, what we call now is multisystem atrophy. So let's try to focus a little bit on physiology and pathophysiology. How REM paralysis this occur? This is a very simple scheme, very simple cartoon, and I know that Pierre Lupi and Jérôme Simel will cry about it because it's so simple. But here we have this muscle paralysis that is normal in REM sleep is like a building, okay? So you have several floors, the hypothalamus, the amygdala, the subceruleus in the pons, the magnocellularis in the medulla, and all these are connected. And if one of them is damaged, if one of these floors of this building is damaged, then the building falls down, and then you don't have muscle paralysis, and then you have REM behavior disorder. For example, if the hypothalamus is damaged, like in narcolepsy, you can have REM behavior disorder. If the amygdala is damaged, for example, in patients with limbic encephalitis, where the lesion here is in the amygdala and not in the brainstem, you can also have REM behavior disorder. You have a lesion in the subceruleus, for example, animal model that the Pierre Lupi group created, the inactivation of the glutamate in the subceruleus. Also, this very clean and neat genetical lesion may also produce REM behavior disorder. And if you have a selective lesion or dysfunction of the magnocellularis in the medulla with an activation of glycine, again, by the group of Pierre Lupi, you can have REM behavior disorder. Also, in the anti-IGLON5 disease, there is REM behavior disorder, which is caused by a select lesion with in the magnocellularis nucleus, and the subceruleus is intact. But what happens in these synucleinopathies, what we call Parkinson's disease, dementia with Lewy bodies, and multisystem atrophy? So these Lewy bodies and neuronal loss are located in the many regions of the brain, like, for example, the hypothalamus, the amygdala, the subceruleus, and the magnocellularis, and this explains why RBD is so common in these neurodegenerative diseases. Which are the synucleinopathies? They are Parkinson's disease, dementia with Lewy bodies, and multisystem atrophy. And from the clinical point of view, these neurodegenerative diseases are characterized by dementia, Parkinson's, and dysautonomia. These are the core main clinical features. And from the pathological point of view, when you dissect the brains, you will see that in Parkinson's disease and dementia with Lewy bodies, you will find alpha-synuclein in intraneuronal Lewy bodies. So we call them Lewy body disease, Parkinson's disease and dementia with Lewy bodies from the anatomical from the post-mortem point of view, it's called Lewy body disease. And the multi-system atrophy, the alpha-synuclein is not in the neuron, is in the intraglial inclusions. So there are two clinical forms of REM behavior disorder, what we call the primary idiopathic and isolated, which is characterized by no overmotor and cognitive complaints, normal neurologic examination, and normal brain MRI that excludes structural lesion like encephalitis or a stroke. And the secondary, it's RBD is secondary to synucleinopathies, 50% of the patient with Parkinson's disease, in about 60% of all the patients diagnosed with dementia with Lewy bodies, and 100% of the patients with multi-system atrophy. And also secondary RBD, like Carlos Schenk explained, can also be found in the anti-IGLON 5 disease, in narcolepsy type 1, in focal structural lesions in the brainstem and limbic system, and in medications. So let's focus on idiopathic REM behavior disorder, and I'll try to explain why this parasomnia represents a neurodegenerative disease, represents prodromal synucleinopathy. First, because most idiopathic REM behavior disorder patients are later on eventually diagnosed with PD, DLB, and MSA. Second, because these patients show the markers of typical manifest Parkinson's disease, dementia with Lewy bodies, and multi-system atrophy. Third, because there is an animal model of RBD that you inoculate synuclein in the brainstem, and then it produces RBD, and later on even Parkinsonian. So it's a model of prodromal Parkinson's disease. And also because synuclein, it can be detected in living and post-mortem patients diagnosed with idiopathic RBD. So like Carlos Schenk explained before, after more or less 15 years of follow-up, of clinical follow-up of your patient with idiopathic RBD, about 45% of them will be diagnosed with Parkinson's disease, fulfilling clinical criteria, 45% dementia with Lewy bodies, 5% multi-system atrophy, and 5% will remain idiopathic. Also, our patients with idiopathic RBD, let me highlight again that they have no cognitive complaints and no motor complaints. If you search on them, you will find that they have the typical markers of Parkinson's disease or dementia with Lewy bodies. For example, advanced age, traumatic brain injury. We have now associated playing soccer, football in Europe to the development idiopathic RBD and later on neurodegenerative disease. And also our patient with idiopathic RBD may display soft motor signs that they are not sufficient to diagnose Parkinsonism, hyposmia, constipation, depression and dysautonomy. Also abnormal cognitive tests. Also, our patients don't complain about memory problems. And if we perform a neuroimaging test, we will find abnormal that is PET, that means loss of dopamine in the substantia nigra, hypercogenicity of the substantia nigra, that reflects increased iron in the substantia nigra, and microglia activation. And this loss of dopamine, iron, and microglia activation in the substantia nigra is exactly what you see in the brains of patients with Parkinson's disease or dementia with Lewy bodies. And also, like I said, during the last 3 years have appeared at least 3 papers in important journals showing that inoculation of synuclein in the subceruleus of a rodent results in RBD and later to Parkinsonism. So this is very important. And also, several authors have found that in our living patient with idiopathic RBD, if we perform a biopsy of several spots in the body, we can find the synuclein, and this cannot be found in controls. For example, it can be found in the colon if we made a colon biopsy, in the submandibular gland here in the neck, in the labial salivary glands in the lip, and in the skin, and in the skin. So in several spots, parts of the body, using immunohistochemistry. But there is a revolutionary new system to detect synuclein also in some fluids and also some tissues. There is RT-Quick that amplifies the protein synuclein if it's detected, and can be found in the olfactory mucosa, in the CSF, and also in the skin. So this is the sensitivity is even higher in the CSF than in other tissues. In the CSF, the sensitivity is very similar to the skin. And also we have few descriptions in the medical literature of patients that were diagnosed with idiopathic RBD and they died. And then we found, the authors found the main character of the disease, which is synuclein. So this is the first description in 1995 by Ukiyama and colleagues in Japan. There is a 86-year-old man with a 22-year history of idiopathic RBD, and he died of pneumonia. And when he died, he had no Parkinsonism, no cognitive decline. And then the authors found brainstem Lewy bodies in the substantia nigra, in the locus coeruleus, in the dorsal raphe, in the PPN, the gigantocellular reticular nucleus, and the dorsal valgus nerve. Remember that in 1995, synuclein was not discovered as one of the main components of the Lewy bodies. But also the Lewy bodies were not only found in the brainstem, but also in the encephalon, like in the hypothalamus and in the main earth. And there was no Lewy bodies in the cortex. So this is another patient from our institution. There is a patient that we diagnosed with REM sleep behavior disorder by polysonogram and clinical history at the age of 69. Then he developed at the age of 72 hyposmia, at the age of 73 abnormal data spect, at the age of 75 depression, a mild cognitive impairment, at the age of 77 constipation, and he died because of a lung cancer, no neurological complications. And when he died, I went to see him a week before he died, and he had no Parkinson's and no dementia, and he was a brain donor. So he died with the diagnosis of idiopathic RBD plus mild cognitive impairment and the other non-motor symptoms. So we found that there was neuronal loss and Lewy pathology in the olfactory bulb, in the dorsal motor nerve vagus, subcerulus, in the substantia nigra part compacta, in the amygdalas, in the main earth, and preserved. The cortex was preserved, was spared, normal, and also alpha-synuclein could be found in the peripheral system, in the autonomic peripheral system. There's another paper published by Carol Shen group, which the patient had a 75-year-old man, 2 years of history of idiopathic RBD, no Parkinson's, 2 years of dementia and death. So he died with the diagnosis of dementia that developed 10 years after the diagnosis of idiopathic RBD. So the authors found in the limbic system Lewy bodies in the amygdala, cingulate gyrons. The brainstem was not available for study, but also they found copathology, neuritic plaques, that it's beta-amyloid abnormalities in the frontal, parietal, and temporal lobes in the cortex, and also neurofibrillary tangles, which is also tau pathology in the hippocampus. So there was a mixture between of Alzheimer's disease pathology and Parkinson's disease pathology. So this is our experience with 20 brains that we have recently submitted. So this all 20 patients were diagnosed with idiopathic RBD using video polysomnography. There were 18 men and 1 woman, 19 men and 1 woman. The mean age at death was 40 years, and the antemortem diagnosis, so before the autopsy was done, was idiopathic RBD in 3, PD in 2, PD plus dementia in 3, and dementia with Lewy bodies in 12. So this is what we found when we analyzed the brains of these patients. That the postmortem diagnosis was multisystem atrophy in 1, Lewy body disease in 19. In 6, the predominant Lewy bodies were found in the limbic system, and in 13 in the cortex, the predominant. But we found copathology in all 20 cases, microangiopathy in 20, Alzheimer's disease pathology in 15, age-related tau astrogliopathy in 12, allergic brain disease in 3, and PSP in 3. But in these cases, the copathology was found, but it was minority. And when we examined the subcerulus and the magnocellularis, there were plenty of synuclein pathology, but not Alzheimer's pathology on the other pathology. So in our 20 brains. The main pathology was synuclein, but there were also plenty of copathology in all 20 cases. So we have found that our patients with idiopathic RBD may develop these diseases, but who of them? I mean, which one will develop Parkinson's disease or dementia with Lewy bodies or multisystem atrophy? Can we guess where this direction will go? This way, the other way, the other way? So this is what we found in our clinical experience. So which is the idiopathic RBD profile towards PD? So our patients with idiopathic RBD that will develop PD are those who have mild Parkinsonian signs, abnormal data spec, hyposmia, normal cognition, dysautonomia, normal MRI, and abnormal MVIG. But this is very unspecific because mild Parkinsonian signs, you can also find it in patients with multisystem atrophy or dementia with Lewy bodies. The same for abnormal data spec. Hyposmia is also seen in dementia with Lewy bodies. Normal cognition is also seen in multisystem atrophy. So this profile is very unspecific, not specific. What about the patients that idiopathic RBD that will develop dementia with Lewy bodies? So we have here in blue some specific points, like for example, abnormal neuropsychological test, mild cognitive impairment, EEG is low during wakefulness, or patients that develop acute delirium, visual hallucinations, or nocturnal ambulation. So these patients also have mild Parkinson's signs, abnormal data spec, hyposmia, dysautonomia, normal MRI, and abnormal MIBG. What is the profile of our patient with idiopathic RBD that will develop multisystem atrophy? So these are these patients who can display stridor during sleep, which is very typical of multisystem atrophy, or MRI abnormalities of MSA, like for example, cerebellar atrophy here, or the hot crash bound. But they also have normal cognition, normosmia, dysautonomia, and so on. So regarding neurodegenerative diseases, the main focus has to be in Parkinson's disease, dementia with Lewy bodies, or multisystem atrophy, but there are few and rare anecdotal descriptions in many other neurodegenerative diseases like PSP, Alzheimer's disease, spinocerebellar ataxia type 2 or type 3, and so on. But these are the main ones that we have to focus, but we have to take in consideration that there are also possibilities. So by three last slides. What is RBD in established idiopathic RBD? So we can say that, so this is the RBD in patients that we have diagnosed with idiopathic PD already. So this occurs in 50% of idiopathic PD have RBD. In 20% of them, RBD preceded Parkinson's, is male predominant, 65% are unaware of dreaming acting behaviors, 20% do not recall nightmares. There's a good response to clonazepam. It's advanced age. Usually they have 70 years old when PD is diagnosed. There is a akinetic rigid motor subtype. There's a fast progression and rapid progression of motor symptoms, and also they have orthostatic hypotension and cognitive impairment. Let me highlight here that some genetic forms of PD also may display REM behavior disorder. And how is RBD in established DLB? So 50% of the patients with DLB have REM behavior disorder. In most of them, RBD present dementia, and is a red flag of the disease because DLB plus dementia RBD plus dementia is equal to DLB and not to Alzheimer's disease, because Alzheimer's disease is not associated with RBD. Here is male predominant, and 50% are unaware of dreaming acting behaviors, 70% don't recall nightmares, and the good response to clonazepam, melatonin is an advanced age, and also we have a full DLB spectrum with Parkinson's, visual hallucinations, and fluctuations. And my slide is to show you how the RBD in established multisystem atrophy. It does occur in 1/100th of the patients. In 50% of RBD presents motor features onset. It's a red flag of disease. There's a Parkinsonian and cerebellar forms in both occurs because it occurs in all the patients. 80% are unaware of dreaming acting behaviors. 30% don't recall nightmares, and like in other forms of RBD, the response to clonazepam is optimal. So let me highlight again, the main known factors of this talk is that abnormalities of REM sleep can be seen in neurodegenerative disease. in REM sleep amount and latency is normal, and RBD is very frequent in neurodegenerative disease, especially in the synucleinopathies in the prodromal stage and when it's already manifested. Thank you very much for your attention.